So these lesions tend to be quite long, 10 to 15 centimeters, and most people will know that it's very rare that you're able to cross through intraluminally, so you end up going subintimal. Now, once you go into the subintimal segment, you have challenges of dissection, how much stenting can you put in there, and then it's an area with high friction, high mobility, and the chances of fractures are quite high and well documented. So it's essential to have tools that will allow you to face and deal with all these challenges. The problem is the moment you go subintimal, half of those tools are lost. So this is why it's important to use new technologies that will help with that. The beauty of it is that you've got a varied range of balloon catheters that you can use, and you can use it whether you've crossed intraluminally or subintimal. What it does is it increases vessel wall compliance, a concept that before in the past, certainly when I was training, wasn't an important factor. But now the more that we do, the more we study, the more we realize, in fact, that vessel compliance is probably the most important factor to limiting or preventing dissection, and also reducing your chances of using stents in very difficult areas. The IVL balloons or catheters, they're very safe. They go into the area, you place them like you would with any balloon. They send sonic waves that act into the intimal medial calcium. In doing so, they crack, increasing the compliance of the vessel wall in a controlled manner. So the chances of dissection are less. Therefore, the chances of complication of the procedure are reduced. So less chances of using stenting, less chances of trashing and having to deal with this distal embolization. This is an 85-year-old lady who presented to us with ulcers located on her second and third toes. They were distressing her because this is an independent, lively patient who was doing everything, walking around and about, but the ulcers became a limiting factor. She was classified as a Rutherford 5. CTA showed a distal SFA occlusive disease due to calcium. This patient was discussed in the CLI MDT and was deemed useful to use IVL because we weren't certain whether we'd be able to cross truly intimately or subintimal. So lithotripsy balloon would allow us to deal with that issue. And also, being an elderly lady, it gives us the option of not having to stent her at this sitting. So IVL in this instance would have been a good tool to use. We're treated under local anesthetic using a 7 French sheath antegrade puncture. We managed to cross the lesion with an 014 Advantage wire. Unfortunately, in this instance, we had to go subintimal. And then we proceeded using a 7mm lithotripsy balloon. We used the entirety of the cycles, and we did a lot of overlapping in areas of interest, so the entry point and exit point. Following the lithotripsy, we found that there was no dissection and no trashing, which meant that we didn't need to stent. I finalized the treatment algorithm by using solution balloon. I used the 7mm, and the final runs demonstrate no distal embolization, no dissection, and fast flow into the foot, which didn't exist before. It's a very simple, easy to use tool. It's not just for the operating clinician, but for the whole team. It's easy to apply. If you can use any balloons, you'll be able to use this. It's very safe. The data backs it up. So all in all, it's one of the very unique tools on the market for managing PAD patients.